At the outset, I have no conflicts of interest to report. Out-of-hospital cardiac arrest is a global public health issue. At the outset, I would like to thank the Scientific Committee of the Cardiological Society of India for inviting me to give the Dr. Amalananda Das Memorial Oration. The fact that the CSI Scientific Committee has chosen this topic for oration exemplifies the importance of out-of-hospital cardiac arrest in India in a low to middle income country and low resource settings in India. Improving survival from out-of-hospital cardiac arrest in India, present status and future perspectives. Of all the forms of inequality, injustice in healthcare is the most shocking and inhumane. There cannot be a better condition or example than out-of-hospital cardiac arrest to exemplify this saying by Martin Luther King. Out-of-hospital cardiac arrest being a global health issue with the survival outcomes almost less than 10% throughout the world. Despite having so much medical technology improving for the last so many years, the survival outcomes in out-of-hospital situation is at a dismal less than 10%, even in the best settings in the world. It is defined as the loss of functional cardiac mechanical activity associated with an absence of systemic circulation outside of a hospital setting. Now, what are the processes which impact the journey of an out-of-hospital cardiac arrest subject elsewhere in the world or in India in particular? The best term I would describe is a situation of panic, a situation of awe, a situation of dismay, and a very dismal state of recovery of OHCA subjects. If we improve these key processes which impact the journey of a OHCA subject, if we can change the turbulent nature of this journey to a full neurological recovery condition where a best chain of survival, a best applied bystander CPR, use of automated defibrillator, and will attain a return of spontaneous circulation at the site of cardiac arrest, and the best EMS with a proper evidence-based cardiac care and recovery and survival outcomes, thereby exemplifying a Utstein survival. Ultimately, this subject of OHCA will enter into a registry which is not for research alone, but for surveillance of OHCA, which is done elsewhere in the world. The ILCOR report, the International Liaison Committee on Resuscitation, described data from various registries, both national and regional, that they describe the data on systems of care from these registries in all countries. The variations in patient outcomes from OHCA have been described and suggested opportunities for improvement in the reporting systems, and so that the disparities in OHCA management are nullified. The survival rate, as I told you, is less than 10%. Across the world, across various countries, there's a 6.6-fold, almost 6-fold difference between survival to hospital discharge and survival to a full neurological outcome at hospital discharge in EMS-treated OHCA settings. On the contrary, a report from the low resource settings showed that a low resource setting like India showed that the OHCA reporting is compromised by reporting bias. The reporting is heterogeneous. There's a need for a framework of standard outcome reporting which is lacking in our country. There's need to develop minimum resuscitation standards in our country, and a need to develop a framework to develop resuscitation systems while balancing other healthcare priorities. So organizations in India in particular and other organizations in low resource settings should be encouraged to introduce measures of data collection with outcomes data based on Utstein protocol or Utstein. Ultimately, the goal in our country in particular is to describe the building blocks in the chain of survival and for a fully functioning chain of survival concept. These are the registries which the ILCOR report has enunciated, like the cardiac arrest registry to enhance survival, the Danish registry, Norwegian, Swedish from UK, Australia, New Zealand, and the Paros registry from Asia. The regional registries are from Arizona, Canada, Helsinki, and Italy. Now, what is the importance of a national registry on OHCA, particularly with reference to India? A OHCA registry, a out of hospital cardiac registry, which is a high quality registry, is a uniform collecting system of data. It gives an epidemiology of OHCA, facilitates inter and intra-system comparisons, identifies the knowledge gaps, supports clinical research, supports surveillance of OHCA in particular, and helps in improving the performance of OHCA care in our setting, and thereby contributing to improving the survival of OHCA. Now, what is this UTSTEAM guidelines? The UTSTEAM guidelines are the consensus reporting guidelines for resuscitation, which comprise of system factors like what is the population served by the EMS or the organizations in that setting, what are the dispatch and recognition factors, the patient variables, and the resuscitation process, like whether CPR was done, how early it was done, what type of CPR, whether AED was used. So in general, a OHCA would include the pre-hospital management is very important, and the in-hospital management of OHCA also would constitute the UTSTEAM guidelines, like the in-hospital management, like whether the targeted temperature management and other coronary angiography. There are various studies on this, how early coronary angio should be done in OHCA setting. See, this is not just ECMO. To reach the stage of a coronary angio or to reach an in-hospital state, the subject needs to attain a return of spontaneous circulation at the site of cardiac arrest, and for which the pre-hospital care is the most important. So with this background, there is a need to address OHCA in India. The increasing burden of cardiovascular disease, which contributes to 25% of mortality in India, two-thirds of NCD mortality being cardiovascular disease, and with the 80% of CVD deaths due to coronary disease and stroke, and with the UN goal of reducing premature mortality from non-communicable diseases in general and cardiovascular disease in particular by 25% by 2025, there is a need for a multi-pronged approach in improving outcomes from out-of-hospital cardiac arrest in India. There is very sparse data on out-of-hospital cardiac arrest in India. With this topic, see the reason for presenting this topic, and for the first time actually I am participating in the national CSI as a faculty, and first time as an oration. I am humbled by this recognition actually. I thank the scientific committee for all this. And coming to the data on out-of-hospital cardiac arrest, there have been previously few studies, very limited data. The first one, the CARO study by Sri Krishna et al. From New Delhi, from Ludhiana, another study, and the Manipal one, which is published recently. These are from the tertiary care setting. But as a practitioner from a very low resource setting, which is a few hundred kilometers from Hyderabad, Warangal, I thought of, and having come across so many out-of-hospital cardiac arrests reported by my patients, it created a passion and dismay in me in translating my dismay and passion to both research and creating awareness on the lay public for the last 22 years. So the first presentation, which was not based on UTSTEAM, I presented in the World Congress of Cardiology in 2016, adult out-of-hospital cardiac arrest in the Indian population. The second one is epidemiology of out-of-hospital cardiac arrest in a Warangal area out-of-hospital cardiac arrest registry. I'm pleased that this is the first registry, particularly in a regional setting, done in India. All the subjects of OHCA attending my alma mater, the MGM hospital, where I am trained earlier in the 1980s, of the non-traumatic cardiac, all trauma cases were excluded. The non-traumatic cardiac arrest cases, the presumed cardiac etiology, overall it came to 814 after excluding the other non-traumatic cases like drowning due to snake bite, due to poisoning and other conditions. We came 814 cases were analyzed. Almost 3 to 4 out of hospital cardiac arrest attending MGM hospital per day for the January 2018 to December 2018, and based on UTSTEAM template, we analyzed it. Now, in this WACAR study, apart from the conventional UTSTEAM template, we included the data on the risk factors, the comorbid illnesses, and prior symptoms to cardiac arrest also. Based on that, I titled it as the modified UTSTEAM template. This study was done with me being a principal investigator, and I am happy that Dr. Murthy and others from the University of Illinois, Chicago, and two of my teachers, Dr. Ravi Kumar and Dr. Sundaresh Peri, were the co-authors in this study, and two of my students from Mamata Medical College and Kakatiya Medical College were the co-authors in this study. This is the first regional registry, and we expect that such registries come over a period of time. The other study is the media report study. an observational study of OHC, a report in Indian print media. This is a out-of-box study. Basically, this is the second such study in the world literature. The first one from the Cardiologist reported in the lay press from UK. They have a system of collecting data, but we don't have such a reporting system in the Indian press. So last 20 years, media reports from the Hindu, Indian Express, Times of India, and other miscellaneous English newspapers were collected, and we analyzed the cardiac arrest by a search word cardiac arrest, and the other things were. So the present status of OHC in India, there is sparse data, low survival rates, the large burden of undiagnosed premorbid conditions, low awareness of cardiovascular disease, there is a fragmented EMS, lack of provision of dispel. So we need to have a goal-oriented OHCA care. The tragedy in life doesn't lie not in reaching your goal. The tragedy lies in having no goal to reach. So with this background, the goals of OHCA systems of care in India are to improve outcomes, have a national OHCA registry, increase awareness on cardiovascular disease, enhance bystander CPR, deploy AEDs as a part of a public access defibrillation system, establish an efficient EMS system, and so that we have a post-cardiac arrest evidence-based care. This chain of survival concept, early recognition, encourage recognition, like the early call to the emergency EM response system, high quality CPR, and apply defibrillation and advanced resuscitation by a proper EMS and post-cardiac arrest care and recovery, which is possible only by a teamwork of rescuers, lay people, emergency dispatchers, first responders, EMS, and hospital providers. Now, at this juncture, I would like to tell about Scotland. Probably they claim that is the only country in the world as of now which has a national strategy to improve OHC outcomes. From 1 in 20 between 2015 to 20 strategy, they are now at a stage of 1 in 10 survivors. So the Scotland Save a Life in Scotland protocol project was started by them, and they have what is called one SMS, one app, where the Good Sam app, I believe, it is the one which will help the first responders to access and give bystander or pre-arrival care. So these are 10 programs of the Global Resuscitation Alliance, from cardiac registry to creating a culture of excellence. So the heart health improvement can be done by preventive measures, targeted CPR training, early diagnosis, the community health screenings, and personal counseling. I would like to mention about the ACs and AHA guidelines, where the prevention of out-of-hospital cardiac arrest, or particularly the sudden cardiac arrest, by following the preventive measures, tobacco cessation measures, individual and population screening, screening for family history, heart failure measures, and electrophysiology measures. These are some of the community programs which we have done earlier. The health education and awareness in rural Telangana, which is recognized by the World Heart Federation as a case study in 2014. The various ways in which you can conduct the community programs throughout. And ultimately, we need a systems of care approach where the pre-arrival care is improved, so that the person, the victim of such cardiac arrest, reaches the hospital. The importance of bystander CPR, which will double or triple the survival after OHCA. One word about uterine survival: if we do the OHCA care properly, the rate of survival is increased among those which are having a witness by bystander and initial rhythm of VF or VT. This is a uterine formula of survival. By combining medical science with educational efficiency and local implementation, the survival of OHCA care can be improved. One of the things which we started for last few years is the National CPR Challenge. This is a very ground level challenge where we teach subjects attending, patients attending our clinic, their attendance, and even among the VIPs who attend our clinic. So a 1:1 challenge can be done so that the OHCA, the bystander CPR increased. This is as a part of the National Initiative of CPR Education, and these are some of the programs which we have done for NCC cadets, NSS cadets. And this is one of the pamphlets in a multilingual way, in a country where different languages are there, through the English and the Telugu, one which we have done. In other languages also, we have done this CPR awareness programs, along with Dr. Vemuri and Ms. Murthy from University of Illinois. A public access defibrillation needs to be improved. Emergency medical services need to be improved throughout the country. There is no single EMS throughout the country, thanks to MRI and 108, but needs to be improved, extended throughout the country. And so the resuscitation systems of care, particularly the heart rescue project, the STEMI programs, are worth mentioning here. So ultimately, we can create a culture of excellence in India, which is teamwork. Ultimately, this is possible This is probably the only condition where a community importance of participation is important. So the instance, one word about COVID-19, even this is COVID-19 has shown that the outcomes are poor throughout the world. One study from Australia showed that there's a disruption of there's a collateral damage due to COVID because of the impact of the OHCA systems of care are disrupted and outcomes have been poor in this condition. So ultimately the take home message is we need through my art program create awareness, conduct research, teaching and training, and ultimately increase awareness on cardiac arrest and CPR, make cardiovascular services accessible, affordable, and thereby increase the accountability. I wish this is one subject where we can integrate the consultation room, the community, the cath lab, and the cardiac care units. Ultimately, we must become the change we want to see. And if you want to go fast, go alone. If you want to go far, go together. I wish that the Cardiological Society of India takes a lead in creating a systems of care OHCA in every aspect. Ultimately, I would like to, last slide, make our OHCA care successful and our efforts.
किसी की मुस्कुराहटों पे हो निसार, किसी का दर्द मिल सके तो ले उधार, किसी के वास्ते हो तेरे दिल में प्यार, जीना इसी का नाम है। किसी की मुस्कुराहटों पे हो निसार, किसी का दर्द मिल सके तो ले उधार,